Institute's Oncology Clinical Pearl Sessions. I'm your host, Nathan Matlock, and I'm the current PGY2 Oncology Pharmacy resident at Monument Health Rapid City Hospital Cancer Care Institute. Today we have something interesting, the Clinical Cancer Advances of 2021. This is a short review of the American Society of Clinical Oncology, or ASCOs, report on progress against cancer. So let's get at it. The Clinical Cancer Advances from American Society of Clinical Oncology highlights the most impactful research advances of the past year and identifies cancer research priorities to accelerate progress against cancer. The report was developed under the direction of a 20-plus person editorial board of experts in different oncology subspecialties, as well as cancer prevention, quality of care, health disparity, and tumor biology. This year's report also discusses the critical issues of health equity in cancer research and solutions to ensure that every patient with cancer everywhere can access the latest advances. Overall, cancer mortality has decreased in the U.S. due to progress in prevention, early detection, and treatment. Unfortunately, these benefits have not been experienced by all. So, for example, African American, rural areas, lower incomes, and education levels. Approximately 8% of adult patients enroll in a clinical trial, and of that 8%, 4 to 6% are African American, 3 to 6% are Latinos, and these represent about 15% of all cancer patients. Another avenue for making research more inclusive is through post-market data collection, and it's very important that we continue that throughout. So the other consideration is the COVID-19 pandemic, which may exacerbate disparities in cancer research. As the coronavirus has been yet another reminder of disparities in access to care and outcomes in the United States, COVID-19 took a greater toll with higher hospitalization and death rates in American Indian and Native Alaskans, Black and Hispanic communities, and among Black and Hispanic patients with cancer in particular. So loss of employment and employment-based insurance coverage have also hit these communities the hardest, presenting additional barriers to participating in clinical research. So in 2017, 4 leading cancer organizations, the American Association for Cancer Research, the American Cancer Society, ASCO, and the National Cancer Institute, or NCI, released a joint position statement entitled Charting the Future of Cancer Health Disparities Research. The statement identified gaps in data available about patients and their communities. So routine collection and reporting of data regarding demographic and clinical characteristics of research participants can increase the likelihood that research will acknowledge and potentially address health disparities, including differences in treatment effectiveness, tolerance, and outcomes. Studies should routinely collect and publicly report aggregated data on demographic and clinical factors, including race, ethnicity, sexual orientation, and gender identity, nativity, ability to status, socioeconomic status, age, comorbidities, and treatment, among others. So in August of 2020, ASCO published its Cancer Disparities and Health Equity Policy Statement, which included a focus on ensuring equitable access to cancer research and stressed that all populations should have an equal opportunity to participate in, be recognized for, and benefit from research across the spectrum, including clinical trials, health services, and other types of research studies and methodologies. Another avenue for making research more inclusive is through post-market data collection, as we mentioned. Using a larger, more representative sample gives physicians and researchers the ability to generate new hypotheses and apply those insights to improve care in real-world settings. Disparities in cancer research is a complex, multifaceted issue requiring a multifactorial response that addresses specific interrelated barriers that preclude certain populations from trial participation, as well as structural and systemic challenges that may limit the cancer community's ability to conduct research that would benefit underserved populations. The barriers that patients face have been broken down into 5 categories. Structural barriers is the first one, and it's defined as having access to a clinic or site offering a clinical trial, including factors such as transportation and its associated costs, health insurance status, and dependent care. Second, clinical barriers. A patient must be eligible to participate in a particular trial. Third, patient attitudes towards the clinical trials. Historically, patients often have reported being nervous about the idea of participating in a clinical trial, although educational efforts and easily understandable informed consent documents may mitigate this. Physicians' attitudes. While most oncologists agree that clinical trials are a high-quality option for many patients, many still fail to offer patients the opportunity to enroll in a clinical trial or treat their patients off protocol rather than officially enroll a patient in the trial in an effort to not accrue additional administrative burden and regulatory liability. So demographic and socioeconomic disparities. The most common demographic disparity is age of the patient. Race as a factor is more mixed depending on the type of trial and disease being studied. Other reasons for low participation rates for all populations range from trial eligibility that excludes patients with comorbidities, financial hardships, and patient misconceptions about clinical trials. When combined, these structural and clinical barriers make trial participation unachievable for more than 3 of 4 patients with cancer. So then we have a strategy to improve equity. Eligibility criteria is one way to make clinical trials available to more patients while simultaneously gathering evidence from a wider swath of the population is to broaden trial eligibility criteria. And then we have umbrella and basket trial design. This is another method by which to expand clinical trial participation is by using umbrella and basket trials, both of which can test several treatments at once across more than one cancer population simultaneously, which potentially could examine and compare the experience of underserved populations. An umbrella trial tests how well new therapies work in patients with the same type of cancer but different gene mutations or biomarkers. A basket trial tests how well therapy works in patients with different types of cancer that have the same gene mutations or biomarkers. Then we have trial availability. So geography presents yet another significant barrier in clinical trial enrollment. Even after a match has been made between an ongoing trial and a patient's cancer type and staging, a 2020 study published in the Journal of American Medical Association examined the location of clinical trials relative to population and found that a lack of a convenient trial location explained for more than 87% of disparities in clinical trial participants. So we have patient education, recruitment, and support. A recent ASCO survey found that significant misconceptions among Americans about clinical trials. Nearly half of all respondents, so 48%, believe patients with cancer who participate in clinical trials are not receiving the best possible care. Although clinical trials may offer the best options for initial treatment, and when the current standard of care is not working for a patient, they may provide a treatment option when no other treatments are available. So increased physician to patient education and expanded community outreach could address this lack of understanding about the true nature of clinical trials. So patient navigation. Other programs that have improved inclusion in research include patient navigation, educational efforts led by the community health workers, and partnerships with community and advocacy organizations. Such efforts can assist with overcoming other known barriers to participation in research, such as transportation and childcare. Novel consent strategies. So these include informed consent practices that are more accessible and understandable to participants from a wide range of cultural and linguistic backgrounds. Methods include multimedia consent content with concise text blocks, visual icons, and videos on smartphone optimized web interfaces. Financial assistance. Although health insurance coverage of costs associated with clinical trial participation are generally covered by Medicare and private payers, Medicaid is not federally required to cover routine care costs, including physician visits and laboratory studies. With nearly 20% of Americans covered under Medicaid, a large swath of individuals with cancer, including those from underrepresented minority and ethnic groups, not well represented in clinical trials, are financially unavailable to participate in potentially life-saving research. So one other thing that ASCO includes annually is their Advance of the Year, which this year is titled Molecular Profiling Drives Progress in GI Cancers. So when we think about GI malignancy, specifically we're coming to mind are esophageal cancer, stomach, small bowel, gallbladder, biliary tract, pancreas, colon, rectum, and the anus. These compose about 26% of all malignancy. So surgery, radiotherapy, and chemotherapy have been the mainstay of treatment with limited results. The development of targeted agent has lagged in comparison to non-small cell lung cancer. So we may be thinking, why is this important? So the ability to molecularly profile a tumor has expanded the treatment option for individual patients with GI cancers, resulting in extending survival while minimizing adverse effects. Specific genetic mutations, amplifications, or fusions, epigenetic profile, protein expression, or other molecular features allow oncologists to choose targeted therapies matched to the molecular profile of their patient's disease. So in the past year, research has shown that the targeting of HER2 improves survival in gastric cancer and shows promise for patients with HER2 positive colorectal cancer. This therapy is now approved that targets specific DNA mutations in metastatic colorectal cancer. These advances are moving treatment of GI cancers closer to personalized medicine. So continuing to look at the advance of the year, specifically looking at the HER2, looking at the mechanism of action. HER2 is a protein that promotes the growth of cancer cells. Overexpression of HER2 occurs among patients with breast, lung, gastric, and gastroesophageal junction cancers, among others. Trastuzumab is a monoclonal antibody that targets HER2, and this ramps down accelerated cancer cell growth and promoting cell death. So trastuzumab plus chemotherapy is the standard and initial treatment for HER2 positive gastric and gastroesophageal cancers, which account for around 20% of these types of cancers. Standard secondary therapy consists of chemotherapy with paclitaxel plus the monoclonal antibody ramucirumab, which act on vascular endothelial growth factor 2, reducing blood supply to tumors. A number of treatments have been investigated for the treatment of gastric and gastroesophageal junction cancers following progression after standard first-line and second-line therapy. So looking at the mechanism of trastuzumab deruxtecan, or Enhertu. So this is a novel antibody drug conjugate that links anti-HER2 trastuzumab with the deruxtecan. It basically targets topoisomerase 1 inhibitor. So this cleaves one strand of DNA, an anti-cancer drug that interrupts DNA replication in cancer cells. Essentially, Enhertu delivers a highly targeted payload of the replication interrupting drug into tumor cells, further triggering cell death. So we can see, if we look at the image here, you see the HER2 receptor on the cell. This is the trastuzumab portion, and then this is the active agent up here at the yellow stars. So what happens is the HER2 receptors internalize all this, lysosomes and circulates and degrades it. It breaks apart, and then you get the active agent being pulled into the nucleus and damaging at that point the cell's DNA. So following the promising results in the phase 1 trial for Enhertu, researchers evaluated efficacy and safety in a phase 2 trial of patients with HER2 positive gastric or gastroesophageal cancers that progressed despite treatment with trastuzumab. So this was the Destiny Gastric 01 study, clinical trial identifier NCT 03329690. Patients were actually randomized or randomly assigned to receive trastuzumab deruxtecan, so that was 125 patients, or the treating clinician's choice of chemotherapy, which was 62 patients. Among patients who received the antibody drug conjugate, 51.3% experienced an objective response, compared with 14.3% of patients who received chemotherapy. Overall survival was also improved with Enhertu at 12.5 months, compared with chemotherapy at 8.4 months. And then the most common grade 3 or greater adverse events were decreased neutrophil count, anemia, and decreased white blood cell count, all of which were more frequent among patients receiving the Enhertu. So 12 patients, 10% who received the antibody drug conjugate, developed drug-related interstitial lung disease or pneumonitis. And then that was mostly grade 1 or 2. And then no cases occurred in the chemotherapy group. So approximately 5% of patients with metastatic colorectal cancer have high microsatellite instability with deficient mismatch repair, which is seen as MSI-H/DMMR, which can be detected when a cell is unable to repair mistakes that are being made during the process of copying its DNA. When this happens, mutations in the DNA start accumulating and may cause cancer. Pembrolizumab is an immune checkpoint inhibitor that blocks the activity of a receptor called PD-1, which is programmed death ligand 1, and it's a protein that helps keep the immune system in check, thereby allowing the immune system to attack other cancer cells. So looking at the mechanism of action a little more in depth, you can see here on the T cell, we have the PD-1 receptors. These are what are going to pick up this PDL ligand 1 or 2. These ligands are projected off of the tumor cell and will bind to the T cell. When this binding occurs, it actually inactivates the T cell. And so the T cell is no longer able to recognize as foreign and mount a response. So we have our agents that either fit in this PD-1 receptor, which would be pembrolizumab or nivolumab, and then we have ones that would bind to the ligand itself, and that's the atezolizumab, avelumab, and durvalumab. So what we do if we block this from happening, we turn basically the T cell back on, and it is then able to recognize cells as tumor, and recognize the tumor cells. Unfortunately, this can cause the T cells to attack the own body's cells and cause an immune-mediated response. So in the phase 3 Keynote 177 trial, first-line treatment with pembrolizumab doubled the time to disease progression, or 16.5 months, compared with patients who received conventional chemotherapy at 8.2 months. The findings come from an interim analysis presented during the virtual scientific program of the 2020 ASCO annual meeting. Severe treatment-related adverse events, so grade 3 or greater, were less common with pembrolizumab at 22% than chemotherapy at 66%. The FDA approved pembrolizumab for the first-line treatment of patients with unresectable metastatic MSI-H/DMMR colorectal cancer in June of 2020. So one of the next things that ASCO presented in this article was that prevention, so aspirin linked to long-term reduction in cancer risk in patients with hereditary cancer predisposition. So Lynch syndrome is an inherited condition associated with an increased risk of multiple types of cancer, and this includes colorectal cancer. The lifetime risk of colorectal cancer is estimated to range from 20 to 80% among patients with Lynch syndrome versus 4 to 5% for the general population. Accumulated data from observational studies and registries suggested a protective benefit associated with aspirin in patients with Lynch syndrome. 20-year follow-up was planned as part of the CAP2 study, which included 427 individuals randomly assigned to receive daily aspirin or placebo for 2 years. The analysis showed a significant, meaningful decrease of 44% in colorectal cancers among Lynch syndrome carriers who took aspirin compared to those who took a placebo. The benefit took more than 5 years to become detectable, but did persist beyond 20 years. Serious adverse events were comparable for the two groups, and the optimal dosage and treatment duration do remain to be determined. So an additional advance was tucatinib plus standard therapy delays the progression of brain metastasis in patients with HER2-positive breast cancer. So looking at the mechanism of action of this, if you look at the image, TKI highly selective for HER2 receptor kinase domain with a minimal EGFR inhibition. So inhibits HER2 and HER3 phosphorylation, resulting in a downstream inhibition of MAPK and AKT signaling and cell proliferation. So which basically results in cell death. So, brain metastases have long been a challenge for patients with HER2-positive breast cancer, developing in up to half of patients. These metastases quickly progress, typically within that 6 to 12-month mark, due to lack of effective treatments beyond localized therapy. Results from the randomized placebo-controlled HER2 CLIMB study changed this by showing that the addition of a new HER2 targeted therapy, tucatinib, to a standard trastuzumab and capecitabine regimen significantly reduced the risk of brain metastasis progression or death. So over the course of the study, this risk fell by just over 2/3 or 68% compared with patients who received placebo with trastuzumab and capecitabine. Patients taking tucatinib also had longer overall survival at 18.1 months versus 12 months. The strong efficacy results established tucatinib as a new standard of care for patients with advanced unresectable or metastatic HER2-positive breast cancer, including patients with brain metastasis who have received one or more prior anti-HER2 regimen in the metastatic setting. So the FDA approved tucatinib in combination with trastuzumab and capecitabine for this patient population. So another advancement, immunotherapy before surgery may improve prognosis of early stage triple-negative breast cancer. So triple-negative breast cancer is the most aggressive subtype of breast cancer. In this cancer, the three most common growth factor receptors that drive breast cancer growth are not overexpressed or not expressed at all. So those are estrogen receptor, progesterone receptor, and your HER2 receptor. Advanced triple-negative breast cancer has an extremely poor prognosis, so preventing the progression in patients with early stage disease is a high unmet medical need and a critical area for research. A number of studies have demonstrated that achieving pathologic complete response when no cancer cells remain in the breast or lymph node from chemotherapy given prior to surgery, so your neoadjuvant chemotherapy, is strongly associated with a better prognosis. The immunotherapy drug pembrolizumab has shown promise in patients with early triple-negative disease. So with the phase 3 Keynote 522 trial, patients with stage 2 or 3 triple-negative breast cancer were randomly assigned to receive neoadjuvant standard platinum-based chemotherapy with either pembrolizumab or placebo, followed by anthracycline and cyclophosphamide with either pembrolizumab or placebo. Patients then went on to surgery, followed by treatment with pembrolizumab or placebo. Then addition of pembrolizumab to chemotherapy improved pathologic complete response, so 64.8% compared with the chemotherapy alone at 51.2%, as well as an event-free and overall survival. So pathologic complete response occurs when no sign of cancer can be found in tissue samples. These promising results suggest that the combination of chemotherapy with immunotherapy may improve long-term outcomes for patients with this disease. So another advance was CDK4/6 inhibitors reducing the risk of early recurrence for high-risk early stage HR or hormone receptor positive HER2 negative breast cancer. So looking at abemaciclib, it's a CDK4/6 inhibitor that blocks retinoblastoma tumor suppressor protein phosphorylation and prevents progression through the cell cycle, resulting in cell cycle arrest at the G1 phase. So it is estimated that up to about 20% of patients with hormone receptor, so HR positive, HER2 negative breast cancer will experience disease recurrence in the first 10 years after a diagnosis. These recurrences are typically distant metastasis and often incurable. Given that over 150,000 patients are diagnosed with HR positive, HER2 negative breast cancer each year in the United States alone, advances in the treatment of this disease may have a substantial impact on the population. Abemaciclib is a cyclin-dependent CDK4/6 inhibitor that works by blocking those certain proteins to slow down the cell growth of cancer cells. It is approved by the FDA as an initial therapy for advanced HR positive, HER2 negative breast cancer based on clinical trials that show substantially improved outcomes for women treated with abemaciclib and traditional endocrine therapy compared with those with that received endocrine therapy alone. So in the phase 3 randomized monarch-E trial, researchers evaluated the addition of abemaciclib to standard adjuvant endocrine therapy in patients with HR positive, HER2 negative early breast cancer with positive lymph nodes and a high risk of recurrence within 5 years of cancer diagnosis. Abemaciclib combined with the endocrine therapy showed a significant improvement in invasive disease-free survival, so 92.2% at 2 years compared with the standard therapy alone at 88.7%. Most patients in the trial did experience at least one treatment-related adverse effect, 97.9% in the abemaciclib group and 86.1% in the standard care group. The most frequent adverse effects were diarrhea, neutropenia, and fatigue in the abemaciclib group, and arthralgia, hot flashes, and fatigue in the standard care group. There was a 16.6% treatment discontinuation rate in the abemaciclib arm. Additional translational studies will help identify who is most likely to benefit from the addition of this therapy, and longer follow-up will help determine whether the use of adjuvant abemaciclib will improve overall survival. However, these early findings are encouraging and represent the first treatment advance in 20 years in the adjuvant setting for this form of breast cancer. So over the past 2 decades, treatment has improved for non-small cell lung cancers with certain identifiable driver mutations, and in the last 5 years, immune checkpoint inhibitors have further transformed the treatment outlook, especially for patients with cancers that do not harbor driver mutations. Checkpoint inhibitors have helped the immune system identify and target cancer cells. Nivolumab and ipilimumab target and different but complementary immune checkpoints. Nivolumab targets the PD-L1, the programmed death ligand 1, a protein that can slow down the immune system's ability to target some cancer cells, whereas ipilimumab acts on a different protein. So, in the open label phase 3 randomized TRECMate 227 trial, investigators demonstrated that the combination of these two agents significantly improved overall survival compared with chemotherapy alone. So this was 17.1 versus 14.9 months in patients newly diagnosed with advanced non-small cell lung cancer and with PD-L1 levels of at least 1% expression, so PD-L1 positive. Median overall survival was also improved with the combination therapy in patients with a PD-L1 expression level of less than 1%. So this was 17.2 months with the combination compared with 12.2 months with chemotherapy alone. So treatment-related serious adverse events of any grade were more common with the combination immunotherapy regimen, so 24.5%, than with the chemotherapy alone at 13.9%. Treatment-related adverse events leading to a discontinuation were also greater in the combination therapy, so 18.1%, than with chemotherapy alone at 9.1%. Hepatocellular carcinoma, or HCC, is the 5th most common cancer worldwide and the 2nd leading cause of cancer-related deaths. When most patients with HCC initially seek care, they have tumors that cannot be removed surgically and have a poorer prognosis. The targeted therapy, sorafenib, has been the mainstay of treatment for HCC that is inoperable, although adverse effects are common and often impair quality of life. In the early trials, the combination of atezolizumab and bevacizumab showed anti-tumor activity against inoperable HCC, and adverse effects were generally tolerable. Atezolizumab is a type of immunotherapy known as a PD-L1 inhibitor that helps the immune system to attack cancer cells. Bevacizumab, on the other hand, is a vascular endothelial growth factor inhibitor that helps limit the blood supply to the tumor. Researchers confirmed the earlier findings of anti-tumor activity in the large randomized phase 3 IMbrave 150 trial, which included 501 patients not previously treated with systemic therapy. Patients were randomly assigned to receive either atezolizumab plus bevacizumab or sorafenib. Overall survival at 12 months was 67.2% for patients who received the combination, compared with 54.6% for those in the sorafenib group. In addition, the estimated median time until the cancer progressed was 6.8 months in the combination and 4.3 months for the sorafenib arm alone. So serious adverse events were more common among patients who received the combination of atezolizumab and bevacizumab at 38%, when comparison to the sorafenib arm that had 30%. Grade 5 adverse events occurred in 4.6% of patients who did receive the combination, compared with 5.8% in the sorafenib arm. So this advancement looked at drug combination extending survival in older patients with acute myeloid leukemia, or AML. So I wanted to start with a couple of the drugs, their mechanism of actions, and how they're going to work. Azacitidine is a hypomethylating agent. It is a pyrimidine nucleoside analog of cytidine that inhibits DNA RNA methyltransferases. This is incorporated into DNA and RNA, reducing that methylation and alters DNA gene expression and decreases protein synthesis. On the other hand, venetoclax activity in tumor cells that overexpress BCL2, these selectively inhibit the anti-apoptotic protein BCL2, which is overexpressed in AML cells. It mediates tumor cell survival by displacing this pro-apoptotic proteins and restores the natural apoptotic process. So acute myeloid leukemia can occur in people of any age, but the disease more commonly affects those that are older, with the average age of diagnosis being about 68 years old. Yet older patients with cancer typically receive less aggressive treatment, often as a result of competing health issues or comorbidities, and you basically have a lack of proven therapies. Azacitidine is a drug that blocks, again, that protein that slows down cancer cell death. Early studies had suggested that adding venetoclax works very similarly to azacitidine may improve survival in other available treatments. So in the phase 3 VIAL-A trial, researchers compared azacitidine-venetoclax combination with azacitidine and placebo among patients who were 75 years of age or older and who had not received prior treatment and could not safely undergo intensive standard care. They found that overall survival was longer for patients who received azacitidine-venetoclax combination, so at 14.7 months, compared to those who had received the azacitidine and placebo, so 9.6 months. Serious side effects were common in both groups, occurring in 83% of patients who received the combination and 73% who received the azacitidine with placebo. Grade 3 or higher hematologic side effects included thrombocytopenia, neutropenia, and febrile neutropenia. So this next advancement is response to HER2 targeting antibody drug conjugates seen in patients with lung cancer. So this is going to looking at Enhertu, and it has shown efficacy in treatment of patients with breast cancer and gastric cancer that make too much of a protein called HER2. The treatment has shown promise for non-small cell lung cancer, and HER2 positivity has been recognized in lung adenocarcinoma for some time, occurring in approximately 2% of cases. However, trials for HER2 inhibitors to date have been disappointing. So, data from the phase 2 Destiny Lung 01 trial was presented in the virtual scientific program of 2020 ASCO annual meeting, where more encouraging data was presented. It showed that 61.9% of the pretreated patients with advanced HER2 positive non-small cell lung cancer who received Enhertu had a confirmed response. The time to disease progression was estimated to be 14 months. More than half, 52.4% of patients had treatment-related adverse events of grade 3 or greater. These included decreased neutrophils and anemia. 5 patients developed drug-related interstitial lung disease. Although longer-term data are needed, Enhertu represents the most promising treatment to date for this population of patients with lung cancer. So looking at this advancement, post-surgery targeted therapy doubling disease-free survival in early EGFR-positive non-small cell lung cancer. So if we look back, platinum-based chemotherapy following surgery has been the recommended treatment for patients with stage 2 to 3A non-small cell lung cancer, although this treatment only reduces the risk of recurrence or death by around 16% compared with surgery alone. Data from the phase 3 ADARA trial offer a promising new option for patients with tumors that have mutated epidermal growth factor receptor gene, so EGFR. The trial found that giving the EGFR targeted drug osimertinib after surgery with or without platinum-based chemotherapy at the clinician's discretion improved 24-month disease-free survival. So that's the time from the treatment to either disease return or the death of the patient. And that made it about 90%. So compared to 44% among patients who received the same surgery and chemotherapy regimen plus placebo. So quite a significant increase. In fact, the trial was unblinded early after this dramatic improvement. It showed a huge increase, and the risk of disease recurrence or death was reduced by about 83%. So this advance is looking at the targeted therapy prompting a response in patients with a non-small cell lung cancer carrying a specific mutation. This mutation is RET, and so basically what I want to do is start by talking about the agents and mechanism of action. We're going to talk about selpercatinib. It's a highly selective for anti-RET. RET is rearranged during transfection kinase inhibitor. This inhibits wild-type RET, multiple mutated RET isoforms, vascular endothelial growth factor 1 and 3, so EGFR 1 and 3, and fibroblast growth factor, so FGFR 1, 2, and 3. Certain point mutations in RET or chromosomal rearrangement involving an in-frame fusion of RET can result in constitutively activated chimeric RET fusion proteins, which may act as an oncogenic driver, prompting tumor cell line proliferation. So it's estimated that about 1 to 2% of patients with non-small cell lung cancer carry a type of genetic mutation called RET fusion, which is involved in the production of abnormal proteins that promote the growth of cancer cells. Selpercatinib is a targeted therapy that works to block these proteins. In the phase 1/2 Liberto 001 trial, researchers evaluated the efficacy and safety of the drug in patients with RET fusion positive non-small cell lung cancer who had previously received platinum-based chemotherapy, so 49 patients, and also those who were previously untreated, so 39 patients. Across both patient groups, researchers observed high, long-lasting responses of patients who had received previous treatment. 64% had an objective response defined as complete or partial response or disease that did not progress. And these responses lasted for a median of 17.5 months. Among patients who had not previously been treated, so about 85% had a response. 90% of these patients continued to respond for at least 6 months of follow-up. So grade 3 and 4 hypertension was the most common adverse event seen, and 6 grade 5 adverse events were observed. Although these were not determined to be related to selpercatinib, overall treatment-related adverse events did not require dose interruption or modification. Although larger trials are needed to confirm these findings, the efficacy of selpercatinib combined with its safety holds promise for patients with non-small cell lung cancer that harbor RET fusion alterations. So here's a slide of additional advances that were in the report. I did not dive into these this time, but I did want to include them for completeness sake. You can see here we have 4 more listed, all very interesting to read in the article and the report. It is free through ASCO, and it is as a PDF, or you can just read it online. Here on this slide, again, just additional advances that we have, and all still very interesting. CAR T cell therapy, improving survival for majority of patients with relapsed or refractory mantle cell lymphomas could be huge, so very interesting to see. Another aspect that we discuss in here is the research priorities. So things that we are going to be looking forward in the future to and what we're going to be doing. So again, another slide of research. Here on this research priority slide, I really want to draw your attention to this 4th bullet, the reduce obesity's impact on cancer incidence and outcomes. So here, the incidence of obesity has dramatically increased over the past several decades. Despite being the 2nd leading preventable cause of cancer, I'll say that again, the 2nd leading preventable cause of cancer, an ASCO survey found that only 35% of Americans actually recognize excess body weight as a cancer risk factor. Obesity is associated with poorer cancer survival and can contribute to increased risk of treatment-related adverse effects. If current trends continue over the next 20 years, it is estimated that obesity will lead to more than 500,000 additional cases of cancer each year in the United States and will surpass smoking as the leading preventable cause of cancer. So here are the references, just simply the 2021 ASCOs report on progress against cancer. So that brings us to questions. That's it, guys. So if you do have any questions, comments, or concerns, please reach out. My email is nmatlock@monument.health. I will get back to you. We can discuss and get everything clarified and answered for you. So that's it for today. I appreciate y'all and look forward to seeing y'all the next time. Y'all have a good one.